Thank you, dear. Most carers of a person with borderline personality disorder know only too well that, as Perry Hoffman has said, and Perry Hoffman is president and co-founder of National Education Alliance of BPD, they know that BPD can wreak havoc not only on those with the disorder but their loved ones as well. So what is it that we carers need to know to help our loved ones as well as ourselves? As the famous song says, let's start at the very beginning. I thought you might break into singing for me. For BPD, the beginning is to get the correct diagnosis. You'd think that this was obvious, and yet so many people who have BPD find it very hard to get the correct diagnosis. So many times those with BPD are given multiple other diagnoses, and yet they don't get better. According again to Perry Hoffman, BPD is the most misunderstood mental illness and consequently is often under-recognised and misdiagnosed. Without the correct diagnosis, we are all flying blind. BPD is not bipolar disorder, nor schizophrenia, nor any other mental illness that you may care to name. While some of the symptoms may overlap, it does have its own diagnostic criteria. By not diagnosing it correctly, clinicians are not doing us or our loved ones any favours. Rather, they are hindering their recovery. And according to Robert Friedel in BPD Demystified, misdiagnosis of borderline disorder is frequently followed by many years of ineffective treatment and growing frustration on the part of the patients and their families, and to decreased hope for the future. I believe it must be diagnosed correctly, and it must be diagnosed early. Andrew Channon, who you heard about this morning from Melbourne, says that recent data from well-designed second-generation studies report positive outcomes for specialised interventions. These findings make early intervention for first presentation BPD the best bet for immediate action. And these positive outcomes are fewer suicidal behaviours, less emergency department use, and fewer hospitalisations. So, if for no other reason, if not for the sake of our loved ones, but for the sake of the budget, the health budget, treatment should be early so that people with BPD are not a burden on the system. Perry Hoffman says 5 years may often elapse before BPD is correctly diagnosed. Why would this be so? Is the delay in diagnosis caused by clinicians' reluctance to diagnose BPD because they think, and I quote, "It is not a good diagnosis and is such a stigmatising illness"? Really? Is it more stigmatising than, say, schizophrenia? Or is it just that BPD has a stigma in the mind of the psychiatrists? So many times we're told by clinicians that they don't want to label someone with BPD because they fear that we, the carers, will stigmatise them. How can we stigmatise them when generally we know nothing about it? When our loved one is first diagnosed with BPD, so doesn't mean a thing to us. However, Joyce Burland, who, I'm sorry, I've got lots of quotes from people, so you'll know that I'm not making it up, she is Director of National Alliance of Mental Illness in the States. Thank you, Marsha. She says there is perhaps no serious mental illness more maligned and misconstrued than borderline personality disorder. That stigma is not in the mind of carers. I believe the stigma of BPD starts at the top with the psychiatrists and filters down through all the people working with these consumers. Some clinicians say that BPD is a garbage bag or a waste basket diagnosis and cannot be treated. According to Valerie Poore, many clinicians may limit the number of BPD patients in their practice as they are too hard to work with, or drop them as they are treatment resistant. So can you please tell us, where do we go then for help, and where do we go for help without stigma? Carers need to know, as we've heard this morning, that there are treatments that can help their loved ones, and they don't need to be tossed in the wastebasket. How many carers are told, as Bob and I were, that we should forget our daughter and leave the state, as people with BPD are just far too hard to cope with, so we should just forget about her and, lead a good life ourselves. I don't know about you, but as a parent, there is no way I can ever do that. There is clear evidence that with the right treatments, people do get better. We need to know what these treatments are and how to access them. Spectrum, in their book Towards Effective Treatment, advise that clinicians must change their pessimistic view about the prognosis and treatment response of BPD and communicate a more optimistic view of the outcome to patients and families. This will also restore confidence among other multidisciplinary team members involved in the treatment. So now we would get the psychiatrists encouraging those, other people working with our loved ones. Having obtained the correct diagnosis, will our loved ones be treated in a non-judgmental manner with empathy and compassion? Will they be treated with understanding and without stigma in EDs and without being called frequent flyers? They have an illness and are not just occupying hospital beds because they're behaving badly or attention seeking. I believe we need to know that the word manipulative is no longer in the vocabulary when describing people who have BPD. The word manipulative is used to convey strong disapproval, and this can lead to clinicians and staff often not providing appropriate treatment. The BPD Society of British Columbia reports most BPD behaviour is not a deliberate attempt to manipulate people or get attention. It is an attempt to get needs met. Our loved ones with BPD are suffering and doing the best they can. They do not need responses that further exacerbate their distress. We need to know that when they self-harm, they will be treated with respect and understanding, not with contempt, and not by being stitched up without an anaesthetic, as we heard this morning. In short, carers need to know that clinicians understand the illness, empathise with their patients' suffering and distress, and follow appropriate guidelines, such as the NICE guidelines, some of which, some of the statements are up on the slide. Carers need information about the illness. In particular, we need to know the symptoms of BPD and how these will affect their behaviour. We need to know how to interact with our loved ones to stop further exacerbating their illness. Again, Perry Hoffman says, people with BPD and their families often do not know that the symptoms and behaviours causing havoc and pain are in fact a mental illness, borderline personality disorder. A commonly expressed sentiment after learning about BPD is, if only we had known. And I know Bob and I can say, if only we had known, our daughter would not have gone through the years of turmoil, and nor would we have. Turmoil, anger, sadness. She first told us she wanted to die when she was 16. She's now 43. BPD was hinted at by about 5 years ago when we were given a sheet of paper Mr. and Mrs. Burke, we think your daughter has BPD. Go away and read this. That was it. No further talk of BPD. And it wasn't till about 2 years ago when a psychiatrist just told us how our daughter was feeling. It has made a huge difference to our life, more importantly, to her life. We need to know the most recent findings of the latest research on BPD and use this information to best help our loved ones. We need to understand their emotional pain, which is actually physically felt, and how this can explain their frequent ED presentations for symptoms other than their mental illness. We need to understand why they self-harm. Why does this seem to relieve some of their pain? We need to know about their fear of abandonment, which may well explain why they fall in a hole when their psychiatrist or family go on holidays. We need to understand their deep sense of shame and make sure we do not add to this by the way we talk to them. We need to know why they say we have abused them when we know this is not true. This is so bewildering and distressing and can harm our relationship with them. We need to know why they say we are the best parents in the world and they couldn't possibly cope without us, and yet the next day they've changed their phone number to cut off all communications with us. How do we set boundaries? While we love our daughters and are willing to be there for them 24 hours a day, we too have feelings and need to be able to tell them when their behaviour is not acceptable. How do we do this without further hurting them? How do we learn to know when to let go, when not to say, do it my way, I know the best way for you to go? How can we learn to say, you're an adult, I know you're responsible, you can make wise decisions, when we're always fearing in the back of our mind that they may go and kill themselves? We need to learn how to do it, and we need clinicians to help us. Why are our loved ones not admitted to hospital, or at best only admitted overnight when they are suicidal? This is the only time we get some respite, and the only time we feel our loved ones are safe. So often they're discharged early as they have our support at home, so we're told, and we're told, oh, just see how you cope. We need to know that they'll be kept in hospital for as long as necessary to overcome the crisis, so we are not the ones to carry the burden. Family members often are on the front line serving as informal case managers or as the de facto crisis intervention workers who handle calls of suicidal behaviours and emergencies. When they're discharged home, we need some sort of handover. We're often excluded from information due to confidentiality, which can even be simple information such as whether our loved one is getting better or not. Is it really such a breach of confidentiality to simply tell us how they are? We need information about their care and to be included in their care planning. Why do clinicians use confidentiality as an excuse for not sharing information with us and not listening to important information we may have to give them? We carers often give the clinician a different and more accurate picture of how they are coping at home. We're told to support but not over-support. What does that mean? We're told that if we visit them in hospital, we're reinforcing their behaviours. Yet how do we reconcile this with their fear of abandonment? Jan Giffen, again from Spectrum, in her paper Family Experiences of BPD, tells of one mother who was told not to check on her daughter during the night because that reinforced her daughter's dependence. Consequently, the mother lay awake thinking how she would feel if her daughter did harm herself that night. We live constantly with the fear that our loved ones may kill themselves. How do we reconcile withdrawing support with the fear of doing more harm? And last but by no means least, we need to know that stigma towards parents of those with BPD will become a thing of the past. Parents has often been blamed for causing their loved ones BPD by abusing them or neglecting them. Yet recent research has found that this is not evidence-based, and it is certainly not helpful. Not all children who have been abused grow up to have BPD, and some people who have grown up in stable, loving families do still develop BPD. John Gunderson, who's one of the gurus in the area of BPD, and again Perry Hoffman, state clearly, many people who have experienced child abuse do not have BPD, and many people with BPD were not abused or maltreated as children. It's an awful burden to think that we may have caused our daughters, and I know there's daughters, sons, and there's spouses as well. At the moment I'm speaking, I will say daughters because it's mainly women. It's a burden that we may have caused our daughters pain, and many of us have needed counselling to show us that we weren't such bad parents as suggested. According to Gunderson and Hoffman, blaming the family has been unsuccessful with schizophrenia and with bipolar disorder, and this is also the case with BPD. While childhood family traumas and even attachment disorder may explain some of the symptoms of BPD, these are not enough to explain the cause of it. So while parents may have made some mistakes, the parents that I have met are loving, caring parents, desperate to help their daughters. The past is history and we cannot undo it. We did the best we could, and now we need to learn the best way to validate their pain and emotional distress. We are the ones who care for our daughters and sons on an ongoing basis, day in, day out. We are there 24 hours a day. We're the ones who try to keep them alive and who grieve with them for their lost hopes and dreams. We're the ones who love them. Thank you.